Great. Well, thank you, Chair and committee members. Thank you for inviting me. It's my pleasure to offer testimony, oral testimony today at the Select Special Committee to address safe supply in Alberta. I have studied, researched, written about drug policy and criminal justice policy for more than 25 years, having been the only drug policy political appointee in both Republican in the George W. Bush and Democratic in the William Jefferson Clinton and Barack Obama administrations. Most recently, from 2009 to 2011, I served in the Obama administration as a senior drug policy advisor to the director of that office. I am currently a fellow at the Institution for Social and Political Studies at Yale University and a co-founder and president with former Congressman Patrick J. Kennedy of SAM, Smart Approaches to Marijuana, a nonprofit public health organization dedicated to working with scientists and policymakers to advance evidence-based marijuana policy. My doctorate is in social policy from Oxford University, and my undergraduate degree in political science and public policy from the University of California, Berkeley. Now, while safe supply is not an accepted medical term, I think it's really important to say that at the outset, that it is a marketing term designed to sell a policy. We in the United States do have lots of examples of physician-prescribed opioids and a long history of opioid proliferation and wide open supply. We have implemented a nearly analogous policy by allowing a supply of opioids to be prescribed via doctors and supplied by pharmaceutical companies. Today, I will share with you the experience of the United States and our version of safe supply of pharmaceutical drugs. Now, to start, it's important for some background. As we've talked about today, grimly, the Centers for Disease Control and Prevention announced recently that there were over 100,000 overdose deaths in the 12-month period ending in April 2021. And we just have new data coming out saying the same thing from other sources, marking an increase of about 30% from the 78,000 deaths during the same period the year before. Of these deaths, these 100,000 or so deaths, the CDC estimated that about 75% of them resulted from the overdoses of opioids, an increase of 35% from the previous year. Now, opioids ranging from prescription painkillers to heroin and synthetic drugs like the fentanyl class of drugs are now responsible for over 75% of overdose deaths. The CDC also found that overdose deaths involving opioids have increased over 6 times since 1999. The Department of Health and Human Services estimated 1.6 million Americans today have an opioid use disorder, and this is generally regarded as an undercount, both in those with an opioid use disorder and also our death count rate, because the data that we have to collect these are not as complete and comprehensive as we would like. In response to these alarming increases in deaths caused by opioids, the Trump administration, the previous administration, declared a public health emergency on October 2017. Similarly, the Biden-Harris administration's White House of Drug Policy has called for an extension of the opioid public health emergency declarations. Policymakers are now taking steps to address the overprescription of licit, legal opioids, such as OxyContin, as well as confront the inflow of illicit opioids, such as those in the fentanyl class of drugs. But it's important to ask how we got here. Nature magazine, the renowned scientific magazine, has argued that it wasn't until the mid-1990s when pharmaceutical companies introduced opioid-based products, and in particular OxyContin, a sustained-release formulation of a decades-old medication called oxycodone, manufactured by Purdue Pharma, that such prescriptions surged and the use of opioids to treat chronic pain became widespread. In other words, these had been around for a very long time, but it wasn't until they were marketed as such, marketed as safe, and supplied in large amounts that this became a much bigger problem. The North Carolina Medical Journal published a study that found several factors have contributed to the over-reliance on opioids for the treatment of chronic pain. Starting in the late 1980s, the medical establishment came under fierce criticism from patient advocacy and other groups for undertreating both malignant and non-malignant pain. This became known as the movement to make pain a fifth vital sign. And in 2017, Medicare structured reimbursement to hospitals, up until then, I should say, we structured reimbursement to hospitals in part on how thoroughly pain was eliminated. So there was an incentive to treat pain and treat pain aggressively. As a result, opioid medications were heavily prescribed and physicians were incentivized to utilize them. And they were incentivized by multiple sources. They were incentivized by government. They were incentivized by business. They were incentivized by shadow groups. And it's very important to understand the influence of a lot of these groups that these groups have on the political system. Being in Canada right now, where I am currently, just in your neighbor province. I wish I could say that the influence of these groups was only confined to the United States, but I've witnessed the influence of these groups also here in our country of Canada. The most recently released National Drug Control Strategy, the one in the Biden-Harris administration, has stated that the overprescribing of drugs, the diversion of prescription drugs for non-medical use, and the lack of accountability or oversight in prescribing practices increase the availability of these drugs in America's homes and workplaces, making them far too easy to fall into the wrong hands. That is the word of President Biden's Drug Policy Office, and I agree with it wholeheartedly. As such, governmental agencies have been working to advance safe prescribing practices, which will try to ensure fewer pills are given to patients and that patients are fully aware of their risks of their medications. A study found, that, for example, that 61% of opioids prescribed following surgery were left over, which amounted to something like 275 milligrams hydrocodone. 27 5 milligram hydrocodone extra tablets per person. Assuming a maximum dose of 6 tablets per day, the average individual was left with enough medication to treat pain for an additional 5 days. Now, let's be clear. The majority of opioid addictions in America started with legal prescription pills found in medicine cabinets at home. In 2017, healthcare providers across the United States wrote almost 200 million prescriptions for opioid pain medications, which is about 60 prescriptions per 100 people, far outpacing the need for pain. NPR reported the oversupply of opioids floods communities with vast quantities of opioid medications that go unused, building up a deadly reservoir of drugs in home medicine cabinets that often wind up being abused. Now, there are many second and third order effects of the opioid epidemic that we often forget. For example, the recent U.S. Commission on Combating Synthetic Opioid Trafficking that RAND was a part of announced in their report that the current overdose crisis has cost the U.S. approximately $1 trillion annually in just the past few years. The costs include greater healthcare costs and lost productivity. In 2021, a study found the opioid epidemic is the primary reason for the reduction in the recent decline of U.S. life expectancy. And JAMA found that drug poisoning deaths contributed to a loss of about a quarter of a year in life expectancy. Most of this loss was unintentional. And so we've seen even effects on the labor force, which obviously is a huge issue right now. Alan Kruger, a professor at Princeton University, found labor force participation has fallen more in areas where more opioid pain medication is prescribed, causing the problem of depressed labor force participation and the opioid crisis to be intertwined. This is causing a huge strain on the foster care system. We rarely talk about the effects on families and children, but it's very important. In the past few years, the number of foster children nationally in the U.S. has risen by 10%. And the Department of Health and Human Services reported that many in the child welfare field think that parental substance abuse, including prescription drugs, illicit drugs, alcohol, marijuana, but especially opioids, has been the primary cause of the increase in foster care placements. There's studies finding that higher rates of overdose deaths and hospitalizations correspond with higher rates of child welfare caseloads. And in a report about the connections between the opioid epidemic and education outcomes, the Brookings Institution concluded that exposure to the opioid epidemic is likely to impact important education outcomes other than test scores, such as attendance, probability of school disciplinary action, graduation, or college enrollment. They also stated the opioid epidemic is a widespread societal problem, and we are only starting to understand the far-reaching consequences that will be borne by individuals and communities. So listen, the bottom line is that we have had experience with a flowing, regulated, medical, legal supply of opioids. And in the United States, it is not going well, and it has not ended well, and we don't think it will end well. I sincerely worry that by flooding willing users with more substances, our problem will be made much, much worse. And again, this goes back to what Dr. Madras and so many others have eloquently stated about availability and use. There are not many truisms in drug policy because this issue is one that is complex, context dependent, and really intertwined with so many issues. But one truism that most scholars agree on, most experts agree on, is that greater availability leads to greater problems because of greater use. Now, that isn't to say that there isn't a role for opioid medications in society? Of course there is. And we have to understand that, we don't want to go back to the other extreme of totally undertreating pain. And that pain is an issue that is important to deal with. But we have seen, it seems often in these policy debates, we want to go from one extreme to the other. And I find that regrettable. So thank you for allowing me to submit testimony today.
Thank you, Doctor, for your comments. We're now going to open up for Q&A with our members. And is there a member that would like to ask a question? Emily, yeah.
Thank you so much, Chair. And Dr. Sabet, thank you so much for taking the time to speak with us. A very thorough presentation. Thank you for speaking in layman's terms for our general public. I guess to summarize your presentation, you've demonstrated that there is a lot of studies and evidence that contradict the concept of safe supply. Is that fair to say?
Absolutely. And really, it should not be seen as a partisan issue by any means. This is something that everybody should be coming together on. We all want to see the reduced incidence of substance use disorder. We all want to see the reduced instances of problems in the foster care system and other systems. And nobody wants to leave anybody suffering that has a legitimate purpose to use certain medications. Now, as we've heard earlier, there are sometimes better medications that are less addictive that should be our first order. Because remember, a lot of these opioids were meant to be used in hospital settings under the strict supervision of physicians in really regulated environments, as opposed to sort of a wide open environment. And my concern with a wide open environment is that we are really opening ourselves up to more problems. And this is not a partisan concern. This is a public health and public safety concern.
Thank you so much for that.
No follow-up? No, sir. All right, Emily Rosen.
Okay, thank you. I just have one question. I will ask you the same question that I asked Dr. Madras, because she said that you may have more of an answer for it coming from that political and research-based lens. But it's been noted, and I think it is interesting to compare the campaign that we've seen from governments against the tobacco industry and tobacco usage over the past couple decades, we will see, compared to the campaign almost for illicit drug use substance by the same governments. So I'm just wondering if you could touch on why you think that there is a difference in those two vastly different campaign tactics for substances that are both probably equally addictive, and who or what you think are driving those different campaign narratives.
Well, it's one of the great paradoxes of our time, to be honest, MLA. It is one of the great paradoxes of drug policy that we would say that we have learned and understand the harms of tobacco and nicotine that can be so severe, and they are. I mean, the legality and normalization of nicotine in North America has cost more than 650,000 lives annually, even now when we know what the harms are and when there's general agreement that we should not expand the use of that drug, of nicotine. And so we have general agreement that we shouldn't expand the use because it's harmful. And we've said that a way not to expand the use is to make sure that we have, heavy regulations, that we have a campaign of discouraging the use of that drug. Why would we turn around and say that rule does not apply to other classes of harmful drugs? Now, there is an important difference and caveat, because we know that there really is no accepted medical use for nicotine, whereas for some of these other drugs, there is accepted medical use. But that is a very fine line between accepted medical use of opioids and misuse and abuse and wide open supply of those drugs. And that latter scenario is what we embraced in the United States for a lot of some of the reasons I just superficially touched on. And it has put us in the position we're at now, because it's introducing a whole class of people as well to drugs that they may not normally have come into contact with. Because again, availability and normalization really does dictate and drive behavior. It doesn't mean that if drugs were legalized tomorrow, everyone in this room is going to go and try them because they're legal. No, but it does mean that certainly young people grow up in an environment of acceptance. And it means that if we have an inclination to try them, if we have an inclination to want to use them, it's much easier to get. Whereas with tobacco, we've said we want to make it harder to get. And so we placed all of these different controls on nicotine, and they've worked. those controls have worked in terms of reducing public health impact and in terms of reducing initiation of use and reducing substance use disorder. So, I do think it is a paradox that on the one hand, we want to approve of some drugs and not approve of others. Again, understanding with the small caveat that there is some accepted use, and no one is saying that we want to, outright prohibit the use. I don't think anybody on this committee, correct me if I'm wrong, is saying we want to outright prohibit the use of medically appropriate opioids used under the care of a competent physician, versus a sort of one of these pain clinics like we had them in Florida or these other places that did not have legitimate medical, supervision. So I think it is a great paradox. It's a great question.
Confirm with that paradox, I think it's safe to say that the campaign against tobacco and to reduce tobacco consumption has been primarily driven by the medical community. But would you say that the other side of that paradox, the drive to increase opioid use, has also been driven by the medical community, or would you say that has been driven by outside sources that go beyond the medical community?
Well, I think a lot. I think it's a lot of it is the latter, unfortunately. Look, now the medical community is certainly, at least in the United States 20 years ago, is partially responsible for the problem we have now because they were incentivized to prescribe, as I mentioned, and they were but they were not. They weren't always like that. They were pushed by companies and a government that went along with it, and other private organizations funded by these industries that had an incentive to increase use, and so they were sort of the messenger in that. They were kind of a third order in that chain. Currently, what I see when I look at the global movement, and it is a global movement to legitimize and legalize all drugs. I mean, let's be very clear. It doesn't stop at cannabis. It's moving to opioids. It's now going to be moving to. We've heard a lot about stimulants and the issue of legalizing crack, cocaine, methamphetamine. It's sort of really all drugs. That is really not driven by the medical community at all. It just like the push to legalize cannabis, both in Canada and the United States, was not pushed by the medical community. In fact, even today, the medical community in the United States generally opposes the full-scale federal legalization and commercialization of marijuana. So, I wish that there would be, the medical community would be driving more of these decisions, but unfortunately, I think they're driven by private parties with their own agendas, either agendas to sell, to sell these substances, which unfortunately we have seen. I mean, I couldn't believe it when I saw that there was actually companies in Canada that were ready to supply, quote unquote, safely these drugs to governments. And again, I think it's really born out of a feeling of helplessness and hopelessness as well by governments saying, you know what? Nothing's working. We don't know what to do. So we're just going to double down on, whatever the most influential interest group is saying and very loudly in our ears. And I have seen that, unfortunately, a little bit in BC, where, again, that's where I am right now. Here in BC, we see, I'm here temporarily, but we see, one of the worst opioid rates in the Western Hemisphere. And we hear more and more calls, I think, to double down on this idea that we should have drugs more available, not less available, not to get people treatment. And that is really what does worry me.
Thank you. MLA Stefan.
Thank you. I didn't get an opportunity to ask this question to our last speaker, but I'd like to ask it to you. And that is, I'm wondering if the term safe supply would be an oxymoron, in that the last speaker suggested that, or asserted that, clean drugs are still not safe drugs. So, So where did the term safe supply even originate? Do you know?
My understanding is that it was really a marketing term by advocates, because the terms are very important. And when you want to make political change, they're very important. And I got to hand it to them. It's a great term, but it's not a medical term. It's not great. It's great politically. And when I put that hat on, as I advised different political administrations, I think that's a great term. I think they did a great job in it, because it gives the impression that you can use drugs safely, that we should encourage the use of drugs, and that because we can do so safely. And to me, that's like saying, if we, teach people where to hold the steering wheel and where they should be looking, then we should be okay with them going, 150 kilometers or 200 kilometers per hour on the highway, because most people who speed, they're not going to get into a car crash. So we could say that's generally safe. And so what do we need speed limits for? We don't need them. We can actually teach people how to do something that is inherently dangerous more, safely. And I think that's certainly the wrong way. Really not helpful at all, because we know that before the fentanyl crisis, which we have, we know that there were still an unacceptable number of overdose deaths, number one. So the idea of a drug overdose didn't just happen when the fentanyls were introduced. And number two, we know that when you encourage the use of certain drugs, let's say a quote unquote clean heroin, you're also backhandedly encouraging the use of all other drugs as well. I mean, addiction is not something that's so neat and tidy and clean that can be easily segmented to, okay, I'm only going to use when I'm given the certain amount by the government, and that's what I've told, that's what I'm going to use. Maybe some people can do that, and hats off to them. But the majority of those having a substance use disorder, that's not how it works. And so for multiple reasons, this has nothing to do with a quote unquote safe supply, but it is a very good marketing term.
So may I ask a supplemental question?
Yes, sir.
Is the promoting of this concept, safe supply, then in some cases deceiving and even increasing harm?
Yes, it is. Because it's giving the impression that we can safely use drugs. It's giving society the impression that it's okay to safely use. Again, I don't doubt that some people use these drugs and their lives aren't ruined. I mean, again, just like some people go 170, 160 kilometers on the highway once or maybe every day for a month, and they don't get into a car crash. Again, that's not a reason to say those things are safe. They're not safe. They increase your risk. When you go over the speed limit, you increase your risk of death, injury, bodily harm, etc. When you use any of these drugs, you greatly increase your risk of a negative consequence, not just you, but to your family and society, which we don't talk about that enough. We don't talk about the victims enough. And so it is a total misnomer from a scientific point of view to call it safe, because there can't be a supply that's safe. Inherently, these are dangerous substances.
Really appreciate you speaking to that. Thanks.
Thanks.
Thank you. Emily Amory, we have next.
Thank you very much, Chair, and good morning to you, Dr. Sabet. And thank you for your time and your willingness to share your expertise with this community. I can't tell you how much we all, I think, appreciate the common sense approach, the simplified answers that you're providing to us, and straightforward and to the point. And I think that's very important for all those who are watching. I wanted to stray away from some of the political discussions with respect to guests before this committee, but I think inevitably questions of politics, of government policy are intertwined with topics like this. And so I ask this of you because from the onset, and in addition to the incredibly capable resume and the breadth of experience that you've demonstrated before this committee this morning, we know full well that you've worked for various U.S. administrations on both sides of the political spectrum. So I would venture to say that you've got a wide array of exposure to the different political ideologies in both Canada and the U.S. With that said, we've heard a very thorough analysis from you with respect to the role of the medical community in opioid prescribing. And I think you mentioned a little bit when you were talking to my colleague, MLA Rosen, about the role of various actors within this entire topic that we're discussing. We could talk about multiple angles, I think, but I want to know if you can impart any information on this committee with respect to what you believe the role and responsibilities of drug manufacturers are in this particular debate. Have they recognized that they play a key role in how their drugs are used? Are they involved in the debate of safe supply at all? What can you tell us about what approaches governments are taking, both south of the border and here in Canada, with respect to what they are asking of drug manufacturers, especially when you mention things like, and I think maybe not a direct quote, but you said just earlier that BC has one of the worst rates of opioid abuse in the Western Hemisphere. I think I'd like to hear from you if you can comment on what responsibility the drug manufacturers are taking and what governments are doing to hold all actors accountable in this particular debate?
Well, thanks for the question. I mean, I think like so many things, sometimes government can be late to the switch and react when things have happened. We were seeing in the United States the undue influence of companies like Purdue Pharma, which right now, I mean, Purdue Pharma is a dirty word to everybody in the United States. You can't utter that word, and there isn't an ounce of sympathy by anybody, which is pretty astounding. I mean, the only people to hold that kind of place in drug history would be the tobacco companies. But I would say that Purdue Pharma is even lower on the rung than even today than the tobacco companies, which also, by the way, willfully lied to the American people and to the really global population for over a century about the harmfulness of their product because they needed people to use a lot of their product to make money. So, and that's really the worry here is that we have private companies that have an incentive for people to use heavily. And that was the issue with Purdue Pharma and other companies in the United States. And there were people in government that tried to raise alarm during this crisis in the mid 2000s and the early 2000s at the time when we were reconsidering what pain was, but they weren't really listened to because those lobbying forces were very strong. I do not know, although I'm here right now, I do not know the Canadian landscape with regards to that as well as I do the American landscape. But I will say that I have been astonished in my very light even research for the work before this committee for today to see the connection between some people that even publish papers on on how great this idea, for example, of safe supply is, their connection to distributing and manufacturing and being part of the supply chain of what would be a quote unquote safe supply. I was actually astonished at that because I did not expect to find that, and I don't have the exact names or anything in front of me now, but I was astonished to see that there were some of those interests, those research, quote unquote research, and corporate interests, or at least supplying interests. I don't know how they've set up their company. It could be a nonprofit. I don't know. But supplying interests that were intertwined. And that was astounding to me because in the US, we are really paying a dear price for really not looking at manufacturers as being responsible. We just kind of the people didn't want to look at them. And I think we have to. I think we have to understand that they do play a role in this. And I think we have to tread very, very lightly if we are flirting with the idea of increasing the availability and use of pharmaceutical drugs and wanting to encourage that, which is what safe supply by definition does. I think we have to tread very lightly because we are dealing with multinational corporations that have intense lobbying capability. Even if you try and write them out of the law, they find ways into it. And again, that's why I really need to stress to this committee that this has to be a bipartisan issue. There's nothing partisan about. We all want to have an open debate and discuss. I don't think anybody wants a closed debate. We want an open debate and discussion. And it was regrettable to me to see the nature of kind of some of the responses even to this committee's inquiry, because it's important to inquire about something that's happening. I mean, frankly, in a lot of countries, including my own, if you didn't like a topic, you never would bring it to a committee and have a hearing. You didn't even want to discuss it. So I think this committee should be lauded for even wanting to have the discussion. But it's regrettable to me that we're not even. I would love to hear from the advocates, and I think you would too. It's regrettable to me that we don't see that, and I don't know if that's out of line to say that or out of order here, or not appropriate. But it's how I feel, especially as sort of somebody that has a heart in both countries. When I look, to Canada, I think about a country that really should value and does value a civic discourse and debate, frankly, a lot more than my own country often does, especially with today's very intense partisanness. So that's regrettable to me.
About 1 minute, Emily Milliken.
I had another question that would probably take me more than a minute to talk about. So what I'll do is I'll just go to a question that I've asked for a couple other presenters, and that is, do you know of any evidence in your experience on both sides of the aisle, all that kind of stuff, do you know of any evidence that showcases that increasing supply or even safe supply, whether or not it can, any evidence to show that it leads to better outcomes for users, and I think you mentioned family and communities as well.
Yeah, no, I mean, the evidence is the opposite. The evidence is when you increase the availability of harmful substances, you get worse outcomes. You get worse outcomes when it comes to children, child welfare, family unity. You get worse outcomes when it comes to hospitalizations and emergency room rates. And you get worse outcomes when it comes to life expectancy and even short-term things like education, workplace issues, and safety. And so, that, again, that is why we have to understand that there is a role for these drugs in a very regulated way, but in the way that is often presented as a so-called safe supply, I worry that that will get out of hand very quickly and produce negative consequences overall.
Thank you, Dr. Sabet, for joining us here today and for your presentation. Hope you enjoy your stay in Canada. You're going to have to come to the other side of the Rockies next time you're up here and check out Alberta. You'll love it if you haven't already. And just appreciate your time and hope you have a great day.